And this is a conversation that I think it's often not talked about. In fact, it's often not even understood or known what it is. So let's begin at the beginning. What is vaginismus?
So, vaginismus is many women that I work with report that they tried to use tampons and they felt like they didn't have a vagina, that there was no opening, that there was such tightness and
Mhm.
closure at their entrance, that there was panic involved with, oh my goodness, something is wrong.
Mhm.
And many women I work with do so because they feel like they should,
Mhm.
because that they've been told that that's normal. Sexual intercourse is normal and that they just need to grin and bear it. What I found to be so distressing about the experience of vaginismus for these women was that it felt like just an area they couldn't like achieve, right? That it was
Mhm.
sort of like goal oriented, like I either can do this or I can't.
Hello and welcome to today's episode of Health University, where we talk about lessons in fertility, pregnancy, perimenopause, all the walks of life that a woman will undergo. And today we're going to talk about something kind of unique. We don't really talk about these things very much, but it's vaginismus. Therapy that works with Dr. Kayla Jiminez. So, Dr. Kayla is a doctor of clinical psychology specializing in women's mental health. She serves as clinical assistant professor at the Stanford School of Medicine and is co-founder of Palmetto Psychology Clinic, a practice dedicated to supporting women across the lifespan. She's designed a workshop on therapist-assisted exposure for vaginismus, which is the topic of the conversation today. And welcome, Dr. Kayla. Do you prefer Dr. Kayla, Dr. Jimenez, or Kayla?
You can call me Kayla. Thank you,
Okay, great, great, great,
Susan.
great. It makes it short and sweet, and it,
Yes,
it
it does.
allows for the, I think, listening and viewing audience to kind of participate in the conversation with a warmer invitation.
Yep,
Yeah,
exactly. I hope so. I hope so.
yeah.
Thank you for having
Well,
me.
my pleasure. Again, this is a conversation that I think it's often not talked about. In fact, it's often not even understood or known what it is. So let's begin at the beginning. What is vaginismus?
So, vaginismus is a biological, psychological, and social sort of experience in which women can have involuntary contractions of their pelvic floor muscles. And when that happens, there can be pain, discomfort at any kind of penetration.
Mhm.
So many women experience this for the first time when they are adolescents, when they are trying to use tampons for their first menstruation.
Mhm.
And many women that I work with report that they tried to use tampons and they felt like they didn't have a vagina, that there was no opening, that there was such tightness and
Mhm.
closure at their entrance,
Mhm.
that there was panic involved with, oh my goodness, something is wrong, something's abnormal about me. And then the social component being there's such shame and stigma around women and their bodies,
Mhm.
particularly around their reproductive health, that many of them don't mention it to anybody, not
Yeah,
to their parents,
yeah.
anybody that they can trust. And so it's really not until they become older and maybe need to get their pap smear for the first time
Right.
that this even gets kind of clocked by a medical provider.
Interesting.
Yep.
And so if someone is discovering upon maybe trying to use a tampon that she's got this terrible pain and then the psychological overlay, if you will, I only can imagine that that exacerbates the physical. Is that an accurate presumption?
Yes, exactly. So this is the pain avoidance cycle that we talk
Mhm.
about with folks, right? That
Mhm.
when there is some kind of discomfort, there tends to be this catastrophic thinking, like I mentioned, that there's something wrong with me, there's an abnormality. And what that does is that tightens our muscles, right?
Mhm.
Which is a normal part of fear and
Mhm.
anxiety, and pain.
Yeah.
And when that happens and they try to approach their body again, and it's met with tightening, more discomfort, more pain, it only further consolidates that notion that indeed something is wrong with
Mhm.
me. So
Mhm.
it's a very difficult and sticky pattern
Yeah.
for folks to get out of.
Yeah, and I imagine by as you mentioned, if they are kind of hiding this from the world, it is amplifying the experience, and by the time they see you, they are kind of in a deeper predicament. Is that also accurate?
Definitely.
Are they able to have any kind of like intimacy, or is it just, I mean, is it the kind of thing where sometimes they're able to experience, the relaxation and the opening of their vagina, but sometimes they're not?
Such a great question, and there's such variability.
Mm,
So, usually, the women I work with vary quite a bit. That on one end, some folks have found ways to really enjoy their sexual life and intimacy outside of penetration.
mhm,
It is not really a bother in the way of, not a bother or distress in the way of their intimacy in their relationship.
mhm,
Maybe there's other things that they're coming in with that they want to be able to have penetrative intercourse or want to be able to have a pap smear.
mhm,
But on the other end, yes, many women I work with are not able to have intercourse, and if they do, it's very painful.
mhm,
And many women I work with do so because they feel like they should,
mhm,
because that they've been told that that's normal, that
mm.
sexual intercourse is normal, and that they just need to grin and bear it.
Oh God.
Um, and so, yes, they can, but it is deeply uncomfortable and
Mhm.
unsatisfying to them.
Okay. All right. So therapy assisted.
Hmm.
Tell us about this. The therapy assisted exposure to vaginismus. What does that mean?
Yeah. So, therapist assisted exposure involves a trained clinician. So, in my case, I'm a clinical psychologist,
Mm,
guiding the patient, so the woman, through gradual, really structured exposure exercises aimed at reducing the fear, the tension, and pain that's associated with vaginal penetration.
mhm,
And so, guided exposures tend to look like, it can be anywhere from utilizing dilators
mhm,
with the therapist. So many of the patients I work with maybe start dilator work with a pelvic floor PT, for example,
mhm, mhm,
beginning to kind of get more an awareness of how to relax their pelvic floor muscles, utilizing dilators. But unlike kind of self-guided approaches that often come with pelvic floor PT work, the
mhm,
therapist in this case really provides real-time support, education, and often emotional processing with the exposure itself.
mhm,
It's really useful because, like I mentioned, there's such variability amongst this population that it allows for really like tailored pacing
mhm,
and direct troubleshooting when there's something that is coming up for them, like maybe an intense fear or panic, like, oh, I move the dilator in this way and it's causing some discomfort.
mhm,
And instead of sort of having to navigate those catastrophic thoughts by themselves,
mhm.
having a therapist to really support them. And
Okay.
I think another piece is like a therapist to support them with accountability, right?
Mm,
It's so understandable for many of the women I work with that there's such avoidance that comes up
mhm.
around this.
Yeah.
And yet it's really congruent with their values and goals that they want to be able to do this.
Yes.
So it's helpful to have a therapist be able to guide them through the exposure
Yeah.
work and help them stay
Yeah.
connected to their motivation and their reasons for wanting to.
And certainly, again, the listening and viewing audience here, these are oftentimes women who want to conceive. They want to have a baby and a family, and so they really do need to, kind of find a pathway to
Mhm.
be able to allow for a vagina to relax and to be able to, either have penetration, have embryo transfer or something like that, and then certainly delivery. So do you then, am I correct in presuming that you work concurrent with a pelvic floor PT, or is that not necessarily required?
Um, It is not a requirement, and I have not yet worked with a woman who has not started
Okay.
with pelvic floor PT. So we work very closely with pelvic floor PT, gynecology, OB-GYNs, right?
Mm,
Um, the patient's PCP. So we really do take a interdisciplinary approach. And for the reasons you just mentioned, a lot of the women are wanting to conceive. So really having a tight connection with their fertility team
mm.
is really helpful.
Excellent, excellent. Now, I mentioned a workshop. So this conversation that I'm hearing you say sounds very individual, very one on one. Is there actually a workshop in which many women are participating at a time, or is this kind of a self-guided individual workshop that they pace themselves through?
So it's a self-guided individual
Okay.
process. So we see them in kind of an individual therapy
Hmm.
context.
Hmm.
And it is something that so many women struggle with that I know my team and I have thought about, like trying to expand this into a more kind of group program or group workshop. Something we're actually trying to work through right now at Stanford is creating something like a women's wellness kind of pap smear clinic.
Hmm.
So many of the women that come to see us are wanting to be able to have, their speculum exam, and it
Hmm.
induces so much anxiety and panic.
Yeah.
So we've thought about maybe like having a group of women come into like an OB-GYN space and be able to share with them like, okay, this is the kind of like room you'll be in. This is what
Hmm.
the speculum is like, those kinds of exposures
Yes.
that might not be so much body focused, but like environmental and stimulus focused.
Right.
So it's been some ideas that have been floated and
I
not
mean,
yet.
I absolutely can see the value, certainly if for no other reason than to demonstrate to any one woman that this, how common this is. If
Mhm.
she can see herself in a room or even a Zoom room with, you know, even if they're, the off camera,
Right.
25, 35 other people at a meeting gathered for this purpose, it kind of takes the sting out of this experience of it being such a uniquely painful event and something, and it would take some of the shame away, I can imagine. And
Yes.
then they can go do their workshop and their one-to-one assisted therapy.
Yeah, absolutely. I think that's probably one of the biggest components of this treatment, right? If we're
Mhm.
thinking about how there's sort of multimodal approach, so exposure is like one piece of it, but I think like exposure, maybe in not its most classical sense, is also about exposing them to other folks who struggle with this. It's actually how I sort of got involved in this more like niche area of
Mhm.
psychology. Was a postdoctoral fellow and was co-leading a group in our women's wellness clinic. It was acceptance and commitment therapy for women with genital and pelvic pain.
Mhm.
And just seeing, like you said, just seeing other women in the space, naming all the different kind of messaging they've received over the years, all the sort of invalidating experiences that they've gotten from their medical care, and being able to see other women struggling with it felt like a
Yeah.
huge intervention and sort of recovery process for so
Yeah.
many of them.
And I just had a thought, in terms of in terms of what it must feel like, what the experience must be if they're going to their OBGYN for a pelvic exam, that OBGYN has not necessarily dedicated enough time. That's a deficiency in the system, not the doctor, but she or he is going to need to just like get through the procedure because there's a line of people waiting for their next appointment as well. And that alone can just both amplify the discomfort and the problem as well as diminish the experience. So I really can see a value in having this kind of thing available in all OB/GYN clinics so that,
Mhm.
if it comes up, kind of at the first meeting, there can be this sort of redirection to saying, okay, you're not alone, and let's get this addressed before we make you suffer through an exam.
Yeah, absolutely. Absolutely. I think that was really the spirit of it is there's such wonderful OB-GYNs I've gotten to coordinate care with who really deeply care about being able
Mhm.
to support these patients because
Mhm.
it's so imperative to
Yeah.
their health.
Yeah.
And so trying to work with that with the confines of, a medical system that
Mhm.
is not offering a ton of time usually.
Yeah.
This has been kind of a nice add-on that we've been trying to play around with. And
Yeah. Please connect with us for a fertility assessment call at the link below. We'd love to learn a bit about you and share our resources. And make sure you subscribe to our YouTube channel so that you never miss an episode. So, how long, if someone were to begin the workshop, what is the length of time? What's the duration? And how long does it take before a woman is beginning to feel like, oh, the possibility of change for herself?
yeah, absolutely. So there's quite a bit of variability, like I mentioned, just given depending where each woman is starting at, sort of her own um, sort of comfort with her body and sort of education up to that point. So We usually start most folks with kind of the education piece.
Mm-hmm.
And I guess the like end place, if there's,
Mm-hmm.
an end place to find, is at the end of exposure when we're kind of doing more like follow-up exposures. And it can really vary from anywhere from like 8 sessions, as little as 8 sessions,
Wow.
to
Okay.
some folks could be like 20 sessions.
I mean, even that's amazing when you think about it. I mean, are these weekly sessions?
We try to see people weekly, if maybe more like a biweekly to monthly cadence. There's
Okay.
a lot of work that we ask folks to do between sessions. So for the
Mm-hmm.
educational piece, for example, it's, reading a lot of materials,
Mm-hmm.
learning a bit about their bodies, their anatomy, doing some exposures with their dilators, working closely with their pelvic floor PT,
Mm-hmm.
doing some exposures at home, right? Of just like, for example, looking at their vulva in the mirror.
Mm-hmm.
Um, and again, kind of like reading materials, looking at photos of a vulva and that kind of thing.
Yeah.
So that kind of work is probably the most flexible and tailored to kind of where the woman is at. Um, and then our exposure sessions are quite short. So something that's really wonderful about it that I tell folks is like, I mean, if we can get you to the place of feeling ready and comfortable to come into clinic and do exposure, usually like 2 to 3 sessions, maybe 4 sessions of exposure
Amazing.
work. Yeah.
Amazing. I mean, it actually almost brings tears to my eyes to think of
Yeah.
for how long this person has suffered and how quickly her body can and really I would say wants to,
Yeah.
relax because body is not designed to be in that level of tension.
Right.
It's something usually has happened. And that raises another question. How often do you see a, sort of an associative or history of either actual sexual abuse or perceived sexual abuse as part of this syndrome, if you can call it a syndrome?
Yeah. Pretty commonly. So it's actually a kind of a way I got involved as well. So, the sort of majority of my training was around working with women who survive sexual trauma. And I think the unsurprising part was seeing how many folks, even after sort of the trauma treatment, a lot of therapy, still remained this presence of kind of a secondary vaginismus,
Mhm.
due to sexual trauma.
Mhm.
Um, and so that was sort of what spurred on my interest of like, okay, and then there has to be more that we can offer these women. So that part maybe didn't surprise me a lot. The part that did surprise me was how many women struggle with vaginismus who have not experienced trauma.
Well, and that's why I said perceived, because somehow in there, as soon as I said it, I thought, oh, I hope that lands as I wish it to land, because it's not to say that it didn't happen, but if it didn't happen, it could still be that a person out of fear of having a female body and fear of what that means for her present and future life, that alone could be enough to create the constraint. Is that accurate?
Yeah, absolutely. I think what I find to be most common in working with this population, more than trauma, is folks who, in general, have had experiences, upbringing, socially, culturally, of just a lot of like shame and sort of kind of like disgust messages about their body,
Hmm.
a lot of sort of stigmatization of women's sexual health.
Hmm.
And then sort of additional layers are like, I think folks, and maybe even just from like a biological perspective, tend to veer more on the kind of like anxious, perfectionistic, a bit more like
Oh,
rigid
interesting.
end of the
Okay.
spectrum.
Okay.
I was surprised by how many women I've worked with who are incredibly successful in most areas of their life, very
Hmm.
high performing women,
Yeah.
smart, really. Kind of like these go-getter women that
The
I,
A-type driven
yes,
CEO. Yes. Hmm.
yes. And what I found to be so distressing about the experience of vaginismus for these women was that it felt like just an area they couldn't like achieve, right? That it was
Hmm.
sort of like goal oriented, like I either can do this or I can't.
Hmm.
And that there was so much distress and like shame associated with
Hmm.
it. So think
Well,
those are,
that is true. We are enculturated to if we do this, then we get that.
yes.
And if that equation doesn't match up, which in life it doesn't always match up,
Mhm.
those who are taught and really, it's imprinted upon them, then just try harder and try harder and try harder and be ashamed if it's not you're not succeeding. So hide it. That would just, again, I think just kind of deepen the problem. I can also imagine that there might be, and I'm speaking from a woman of a certain age where certainly in my history, religion played a part in it. So, and I think that I can well imagine that there's some women who, were raised as girls to say, oh, well, girls don't even pay attention to down there.
Yes,
Hmm.
yes,
Hmm.
absolutely, absolutely. I think that's very true for a lot of the women that I work with,
Hmm.
that there's a lot of cultural, religious sort of beliefs and teachings that really veered them away from um, curiosity about their body, right?
Right,
Like
right,
normal,
right.
healthy exploration that instead was sort of embedded in sort of messages like, that their body is sort of like a machine that it needs to do what it needs to do, and if it can't, then like then you're doing something wrong.
Yeah. Yeah.
So
And
I think
yet again, in my own sort of activism uh, inclination, I want to say you would not be given this beautiful body if it
Mhm.
weren't to enjoy it fully and to really, appreciate all of what it's offering you so that it is not something to be, ashamed of or try to look away from. But, really this is part of our body. We look at our eyes. We check our teeth, we love
Yeah,
our hair, but but we're all trained like, oh, don't do that. Don't touch there. Don't, yeah, yeah.
yeah, exactly. And I think that I appreciate you naming kind of like the activism piece. I think that's why I feel so passionate about this work, and it's
Mhm.
really just registered as so very important, because I realized, kind of going back to the timeline question, that like when given the education, when given the corrective learning that your body is not meant to be a machine, but actually like a beautiful aspect of your being that you can explore and get curious about, and is nuanced to you, that like it just opens up so much for women, that it almost feels like I don't have to do much, quote unquote, to like
Yeah.
really allow them to get in touch with this part of themselves that can be so
Well, that's
important.
beautiful. And it gives me chills on this hot day up here
Yeah.
because it tells me that just behind the veil of I can't and this hurts and all of that lies the capital T truth of course, of course I'm allowed to. This is like that. This is why I have this beautiful body that I have, is to fully express it
Yeah.
and fully express love for myself and love for life and love for other whoever, if that is the case. So how does a woman, and forgive me, I know that I'm old, so I'm using pronouns. I apologize. How does this person like find the tribe, the team that's going to help? Because I imagine that you're licensed in the state of California. Are you able to help people outside of the state of California?
So at this time, I can provide like consultation for teams outside of the state of California. But in
Hmm.
terms of my credentials and my licensing, it is in California. So
Yeah,
we
yeah.
work with patients in California.
Is there a national organization?
There's not a national
I
organization.
think I see one happening in your future.
I know,
I
I
think I
know.
see you spearheading one because truly, again, if somebody just happens to be listening in from Colorado and says, "Well, I can't get to California and I have the need. How do I find this resource?" I would love off camera, let's put our heads together and see
Yeah.
how we can, really team up to find there's got to be the connection there somewhere, either in, American College of Obstetricians and Gynecology, American Society of Reproductive Medicine, lots of organizations exist that could probably weave this into their charters already, so that this entire field, because I imagine there are people like yourself across the country, hopefully around the world, who are able to and have the desire to help these women.
Yeah, absolutely. Yes, there's certainly folks internationally that are doing this work and have it more
Hmm.
embedded into their system. So we could probably learn from them.
Can you say more about that? Because I think that to really understand that this is, something of a uniquely U.S. conservative
Yeah.
culture that we don't really understand, that does not have to be typical around the world.
Yeah, definitely. So the developers and the researchers who created this treatment are based out of the Netherlands.
Hmm.
So unsurprising there, a lot of our best treatments
Yes.
around human sexuality and sexual health come out of Netherlands.
Mhm.
And then there's a team in Canada as well, and I'm blanking right now, so apologies to that
That's
team
okay.
of where they're based out of.
You can let me know and we'll make sure it goes into the show notes because
Perfect,
we want people
perfect.
to have access. Hmm.
Yes. But from my understanding, at least on the West Coast, we are the only team that offers this treatment. And so my work has been really kind of doing this at Stanford and then trying to expand upon and figure out ways that I can support folks in private practice as well.
Hmm. Hmm.
Um, so a little bit different in the private practice setting because I currently don't partner with a OB-GYN clinic to be able to do the in-clinic exposures, but I really work with folks to be able to offer them the education on the front end, the exposures they can do at home that I do at Stanford as well. So trying to figure out ways to expand it in my small
Yeah.
neck of the woods.
Yeah.
But certainly, I think next steps would be trying to consult and kind of
Yeah.
expand it further.
Yeah, I mean, I really can imagine that there must be a way in which to at least, deliver the information, either PDF or video or something like that, so that that person can at least have access to, oh, this is available to me through login modules, so there's privacy around it and all of that. But yeah, I'm excited for that possibility because it is, as you've mentioned, a much bigger problem that we are willing to admit, able to know, and certainly able to understand. If there's a person out there listening who is in California or outside of California, what would be your kind of like message to that person? Like before we sign off on this conversation, please know that.
Mhm. I think please know that you can trust your gut and your intuition.
Mm,
And that if it feels like something is off, really advocate for yourself to your primary care provider. And that there are resources out there, even if it's not therapist, assisted exposure, that there are strong, solid, evidence-based practices for treating vaginismus.
mm,
And connecting with your OB-GYN, getting connected to referrals with pelvic floor PT,
mhm,
individual therapy. There's a lot of really great treatments that we have, and that it's not in your head, and that pain is not normal. It's
mhm.
common, but it's not normal.
Right.
So, really, I think encouraging folks to trust their gut that like something feels wrong, that it's worth exploring.
Yeah. And if I may add to that, I would say that somebody who might not be listening would be right now the 16, 17, 18-year-old who does not have like legal authority perhaps to, that person is still under parental care. So if you're listening to this and you know of younger, girls who might be struggling, if maybe there's a way to ask them how they're doing. Do they need help? I don't know at what age a teenager goes first to for her first pap smear. Is it 21?
I believe it's 21,
Okay,
which
that
is,
that could be pretty late in the game. I mean, that person could,
yeah,
because she's been menstruating since she was maybe
early.
12.
Yeah,
It's like almost 10
yeah.
of struggling. So it would be really great to find a way. So listening, viewing audience, I'm also calling on the activists within you to just think for yourself how the people you love, the people who you care about, who may be struggling. And there's only one way to find out is to normalize the conversation and to ask, how are you doing? Do you struggle with putting in a tampon? Is it painful? Are you afraid? And then help that person find resources through, through whatever resources are available.
Yep,
Yeah.
absolutely. Absolutely. I think the messaging of curiosity is kind of the big thing I try to
Hmm.
encourage folks to take away because
Hmm.
that's what was missing in their adolescence, right? The genuine curiosity of like, huh, this doesn't feel great. What could that mean? Oh,
Hmm.
wait, actually, when I am more relaxed, it goes in much easier versus when I'm stressed.
Hmm.
Um, I
Hmm.
think that's sort of the missing link, right? For a lot of young kids is like no one gets to hold that curiosity towards them of like, huh, what's your experience like?
Yeah. 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 Okay, boy, the wheels are turning here, so I think we're going to have to circle back another time. I always want to be respectful of your and the viewing audience's time because we usually can dedicate about 25, 30 minutes and then we have to get on to our next thing in our busy world. So I want to thank you for your time. I really and all of the resources, the Palmetto Psychology website will be in the show notes. If there's any, excuse me, other resources you can recommend, I'll be sure to get those in as well so that people can reach out to you directly.
Perfect. Thank you so much for having me, Susan.
My pleasure. So good to see you.
You too.
And we finish all of our conversations at Health University with the reminder that life is a lesson. And whether you are in your fertility years, your pregnancy years, your perimenopausal years, there's a lesson at each path, at each step across that bridge. So be sure to stay tuned. And for now, we will say class dismissed. If you want more episodes like this at Health University, and make sure you subscribe to our YouTube channel. Thanks for watching, and we'll catch you at our next episode of Health University. But for now, class dismissed.